My name is Polly Pittman. I would like to welcome you to our second Health Workforce Research lunch of the fall. This series is actually funded by the university. We're very fortunate to be able to have it be filmed and shared with those outside the university, and our interest is trying to expose and grow the field of health services research in the area of workforce policy. We have a collaborative agreement with HRSA to do health workforce research, and many of the faculty here are involved in that project. And I'm also very excited to announce that the university has just approved a new Institute for Health Workforce Research and Policy, which is an institute that will span several schools. The primary group will be the School of Public Health, the School of Nursing, and the School of Medicine and Health Sciences. But we also have faculty from Trachtenberg School of Public Policy, School of Business, School of Education. And the idea is really to bring together an interdisciplinary group of faculty and students and staff to grow the field of health workforce research. So there's never been a center like that here in DC. We think that this is a really interesting opportunity to expand the focus on the federal side of health workforce policy. There's been a lot of work on the state side, which is really important, but not as much work on the federal side. So you all will be hearing from us, not only in regard to this speaker series, but in regard to the work of building this institute. We hope you'll all be involved. I will be co-directing the institute with Dr. Fitzmullen, and I'm going to let Fitz introduce our speaker today, and I'm very excited to have Dr. Klintz here with us today.
We are delighted to have Kathleen with us today, and I'm very pleased to introduce her. We go back a number of years in the same part of the forest that we think is the whole forest. Turns out there's a little more out there that doesn't always agree with us, but we work on that. In any event, Kathleen is a family physician who headed up what I didn't know existed at the time, which was a program in family medicine at Columbia at Presbyterian Hospital, and maybe we'll talk a little bit about that, but came down to Washington as a RWJ policy fellow in 2007 and worked for Hillary Clinton, actually, so got Washington fever and came back shortly thereafter as the director of the Division of Medicine and Dentistry in the Bureau, what was the Bureau of Health Professions, now is the Bureau of Health Workforce. See how the name is everywhere, in HRSA. And in that role, she really played a major leadership role in particularly the Title VII programs, which fund a lot of the primary care clinical work, training work particularly, as well as a bit of intellectual work, including Council on Graduate Medical Education, which is hosted there, and she played an important role in. And then recently left HRSA and came to the Graham Center, which she'll tell you more about, but is a wonderful institution that is probably the primo primary care policy think tank in the country. It is funded or supported by, as part of the American Academy of Family Practice, which is a natural place for it to be, but their work that I've been involved in and read and been smitten by over the years goes beyond simply family medicine and simply primary care per se, but the whole landscape of healthcare delivery with an important emphasis on primary care and its importance. So she's going to tell us, I believe, about her work there and going forward. But we're delighted to have you, Kathleen.
It's true. My name's Kathleen Klink. I'm a dyed-in-the-wool family physician. I knew when I went to medical school I wanted to be a family doctor. I went through training in medicine and then family medicine at the University of Miami during the time when we were right in the beginning of the crack cocaine epidemic. We were right in the beginning of HIV diagnosis. There was a Haitian immigrants landing on the shores of Miami. Many women who were pregnant and got into leaky boats so that their children would be born in the United States. And all those social determinants of health and prior experiences, both poverty, the migrant workers that we cared for in southern Miami, where I did my continuity of care as a family practice resident, informed, I think, what my philosophy about medicine has become. Right after residency, I went to New York City, where we have some similar roots, and worked in a community health center and spent my 20-some plus years working in vulnerable communities in New York City, one of which is Upper Manhattan, this site where it formerly was Presbyterian Hospital, it's now New York Presbyterian Hospital, and was in the founding faculty of the Family Medicine Residency Training Program there when we thought that primary care was going to take over the world in 1996, and we all have an idea what has happened since then. But that was an exciting opportunity. And so here we are today. I'm the medical director at the Graham Center. I'm totally overwhelmed by all the exciting information and trends and everything that's going on at the Graham Center. I'm going to try to just give you today sort of a potpourri of things that are going on. It's going to be a little bit more physician-oriented maybe than some of you are used to, but I'm certainly going to try to talk about team care and the approach to care and try to at least refer to the context of population health, although the focus of the talk is really, as much as anything, on workforce training of physicians. So I'm going to talk a little bit, because he died this year, give a little tribute to G. Gale Stevens and talk a little bit about the social mission of family medicine as it started out back in the 60s and 70s. Spotlight a little bit on our system, the ecology of care, what we call the ecology care training. Give you a little bit of a sense about what it means to be a generalist, because I don't think we talk that much about that. I'm going to use sort of tag it to a report that came out from across the pond, Great Britain. And then I'm going to talk a little bit about the comprehensiveness of care being an important determinant in terms of outcomes, and how training does matter, how we train our residents in residency training programs, as well as other clinicians in their training matters. And then try to align some of these practice patterns with complexity, and how can we sort of improve the practice of primary care. And then talk a little bit about the future in investing in primary care. So do all that in 15 minutes or less now. So I just wanted to give you, this is a quote from G. Gale Stevens, and it's really, it says, "We developed a movement of social reform rather than a discipline of science and technology. We were committed to serving the underserved with, quote unquote, first-class medicine, and to seek the value of health beyond mere relief of pain or diagnosis of disease." And I think as we are trying to unravel some of the current problems that are pertaining to social determinants of health, health equity, health disparities, that these words continue to be relevant today. Stevens wrote Family Medicine as Counterculture in 1978, and also published The Intellectual Basis of Family Practice in 78, and then was published again in 1989. And please forgive me, because I want to read a quote by him, which I think, to me, informs so much about what we think about and talk about when we talk about primary care. And I think sometimes we, in our research hats, in our day-to-day data, forget what we're really trying to do. So he says, "Personal medicine is the guiding light, or the red thread that illuminates and identifies our path amidst the many vocational diversions that allure and tantalize us. It can coexist along with the many epiphenomena of family practice: primary care, preventive medicine, geriatric medicine, behavioral medicine, family medicine, sports medicine, procedural medicine, even emergency medicine. But when one of these becomes such an obsession that it crowds out personal medicine, our identity as family physicians is compromised." And I think those of you who are physicians in the room recognize the power of that personal relationship that really defines and should continue to define what primary care and particularly family medicine is. He says, "As we struggle to direct our own evolution, that is, the evolution of the discipline of family medicine, let's not be intimidated or enticed to give up our most indispensable ideal, personal medicine. The need for it will never become passé, although we must continue to learn what it means and how to do it." And I think that that's a challenge that those of us who provide primary care are constantly up against. How can we provide the best care, the most effective care, retain our personal relationships with our patients, and yet work within a system that's becoming more and more and more complex as we go forward? So just to kind of dwell on this issue of complexity and modern generalism, the Royal College of General Practitioners and the Health Foundation in Great Britain commissioned a report which was published in 2011. And basically what the report came out came out to say was that the concept of generalism, of true generalism, is one of the hardest things to do well. Well, that's the opposite of the message that you get when you go through medical school, those of you who have been in medical school, and many of you who are clinicians and nursing and others, that, you know, oh, the message is you're going to do primary care, you really should specialize because that's what's elite. And that's what we pay for in our nation, right? And so this is my quote. Turns out family medicine is rocket science, after all. So what they basically said is that, in the Commission's report, is that generalism is really a way of looking at the world. And I think that it's really true if we have sometimes I call people groupers versus splitters. I think we generalists tend to be more groupers and not the fish. Though I love deep grouper. But what this Commission report basically said was that generalism being a way of looking at the world, you sort of accept the variation and you accept the context of health and ill health as part of the wider vision of the world, in the sense of what are the social determinants, what are the family values, what are the population needs, et cetera. As you assess and care for your patients. And they said one of the remarks that came out of the report was that young doctors, that is physicians who are seeking their training, really need to decide what interests them. Is it the disease, the science of the disease? Is it the genomics, the molecular structure of particular treatments, which is interesting and important? Or is it the way disease affects people? And I think that that's, to some extent, the sort of decision tree that a lot of young physicians and other clinicians make as they go through their training. So they left, the Commission left the Royal College of General Practitioners with 3 challenges. The first being, this is the real world. We're facing increasing complexity. We agree generalism is important, but how are you going to deal with it? The second is the public expectation. People in Great Britain, just like the United States, have access to the internet, and those of you who are sophisticated, when your elbow hurts, you go to Google, left elbow, and find out what it could be, and you go to the doctor and say, I think this is it, and then you decide whether you should have your MRI. Often people want their MRI right away, et cetera. So the public expectation is really shifting as we have advertising on television for pharmaceuticals and all other kinds of things. And then the third thing is, what is the sustainability of primary care? Are we going to be able to sustain in the squeeze of more and more expectations as we go forward? And that was a challenge that they were left with. Do I have the answers to these questions? No, but I think that these researchers and you all are sort of left with trying to figure out how we're going to solve some of these problems. So just shifting back to the United States, this is the horizontal line is the healthcare spending per capita. This is not a new slide to you all. And then the life expectancy in years, and you can see where the USA is very expensive for a lower number of life expectancy years. Up where I have the arrow pointing is some other nations, OECD nations, who have employed pretty robust primary care, and they're seeing lower costs and higher life expectancy. So that gives us an idea of kind of where we are in the world of our healthcare system. The IOM report that came out in 2013, Shorter Lives, Poorer Health, looking at the United States from an international perspective, compared, you see the red dots going across, the life expectancy of women in the United States is not keeping up with, as you see, the confidence intervals of life expectancy from the other OECD nations. So we're not keeping up, even though we're spending more. So just to think a little bit about what has been referred to as the ecology of medicine, that is people who, 1,000 people, what kind of health care do they need if you look at 1,000 people? Over the period of over a period of, I think this was a month's period of time. Yeah, a month. So 800 are going to have that sore elbow. They're going to have some symptoms. You might have seen this before, I'm not sure. This was originally done by Kerr White and updated by the Graham Center in about 2000, I think. 300 some consider seeking medical care. Another 200 some visit doctor's office, half of which are primary care visits. Another 65 go to an alternative provider, and 21 will visit a hospital-based clinic. We see another 14 receiving home care, sort of health-related. 13 visit emergency departments. 8 are hospitalized. If you have a panel of 1,000 patients, you can expect, as a physician, to have about 8 hospitalizations a month. I think that's about average. And then less than 1 is treated in an academic hospital and health center. And where is 99% of our training of our clinicians and our workforce, but in academic health centers? So it sort of makes us wonder, why are we... This was, it was done in originally 61, and it was updated in 2001, I think.
And it'd be interesting to see between 2001 and now how it's changed.
Yeah, between 1961 and 2001, it hadn't changed much. It was quite constant. Carway had less boxes, but showing the same thing. And it was one in academic health center. He called it University Medical Center, I think was his designation.
At the time, yeah. I think Andrew Bazemore might have done some updating of this in 2009, but I don't have that information. So as we're kind of pointing out, most of the graduate medical education takes place in academic health centers where, not that many people are seeking care. And if you just take a look at what the hospitals are doing in terms of GME, if you look across the bottom, the horizontal axis, that's average salaries for the specialty, and then the vertical axis is the change from 1998 to 2007 and the number of GME PGY1 slots being offered. So the hospitals, basically teaching hospitals, those who are recipients of GME monies from the government, can decide which specialists they want to train and how they spend their money. That's really where the decisions are made. And as you can see, pediatrics, Dr. Mullen's specialty, and family medicine, mine, the number of PGY1 first-year postgraduate positions had decreased in 2007, and the higher-paying specialties, dermatology, radiology, anesthesiology, are much higher. So that's how the GME is being sort of changed, shifted, and where our investments are going. It's into higher, not only paying for the individual physicians, but also paying for procedures and diagnoses that are more advantageous to the teaching hospitals. Just looking at production, and this is probably an overestimate. Currently, looks like we're producing about 25% of our workforce going into primary care. I think it's a little generous. It's probably a little less than that, because we know that a high percentage of internal medicine graduates are staying in hospitalist care, so it's not really primary care, it's just lack of specialty. And it's always important to remember that primary care is not simply just lack of specialty. It's also the comprehensiveness and continuous first access care that we know to be personal medicine of primary care. If we look at our current workforce, it's about 32%. The 20th report from COGME, Council on Graduate Medical Education, which advises the Secretary in Congress, Secretary of Health and Human Services in Congress, said that there should be at least 40%. I actually happen to know that there were people on that panel who were pushing for 50%. So we have at least a benchmark of 40%, and our current production is really much less than that, maybe even half of that. So trends in healthcare providers, I think maybe Ed Salzberg might have shown you this slide last time. If you look at right across the bottom, this is family and general physicians. Actually, interestingly, the ratio of physicians to population hasn't really changed that much, right? It's just that the population has grown. And the population is aging and is more complex, as we mentioned earlier, so that we're not sure if we're keeping up with the need, even though the ratio is very similar over the years from 1988, and this ends in 2008. We see that the medical specialists are increasing, similar to the GME slide I just showed a second ago. And then if you look at the nurse practitioners and physician's assistants, we're seeing that there's quite a shift in the number of nurse practitioners and physician's assistants coming out. There's a distribution issue. So even though we have the population to the physician to population ratio has been steady, if we look at those who are saying they're going to go into practice in rural communities, Currently, our production is less than 5%. But that's a problem because sorry?
On the last slide that you had about sort of production by, I presume that this is, by production, you're talking about this is the number of new, for example, people who are family, general, MD residents coming out, and the number of new nurse practitioners. So it's not measuring what's the prevalence of the population, particularly to the extent that you might think that in some fields their career is shorter than other fields.
I'm not sure I'm understanding what you...
The annual graduation rates.
It's annual graduation rates as opposed to what percent of people are within the overall population.
It is, yeah, sorry, per 100,000.
It's the aggregate trends, right?
But aggregate trends in terms of the total number of people in that field or the number of new graduates?
I think that this slide, this is the total number in practice in the field. I think that's right.
I don't think so.
No?
Nurse practitioner PA lines are going up at that.
At that rate, it must be in the graduate.
Yeah, graduates, not in.
I have the graduate slide in the next, I'll just go forward to it, right here. So we have the number of graduates, maybe this will clarify it. In 2002, from nurse practitioners, around 7,000, and then doubling in 2012.
Yeah.
So that's graduates.
But I think in terms of Leighton's question, those rates are rates of graduation in the surgical specialties, other specialties, medical subspecialty. So what you're reflecting here is a very rapid increase in graduates going into medical subspecialties, the most dramatic one.
That's just part of the point is things like nurse practitioners, people may feel, have a shorter average career, so that even if the number of new graduates is going up, you know, to the extent that they're also exiting faster than MDs, perhaps. And again, I could be wrong. Then you know you might.
I don't know
have
that that's
reflects
yeah.
in terms of the actual
practitioners
who are actually serving patients. The ratios could be quite different.
And the graduates every year, I mean, this is a prime dynamic of workforce studies. If you're tracking the graduates, they go into a much larger pool. So it takes many more years for the pool to rise to that level.
Right.
Because you're putting a little...
in that profession is
right.
bigger as a percentage of total.
Yeah.
When we're seeing a similar trend in terms of graduates with the PAs. So maybe this is showing that. I apologize, I'm not sure. Just getting back to the distribution issue in terms of the rural production, we have less than 5% intending to go into rural practice, and then of course currently the proportion of physicians who are in rural practice is a little more than 10% with the population of 19%. So we're not keeping up with the distribution into the rural workforce either. So I just showed these trends in terms of training. The issue becomes, of course, similarly with physicians, that the physician assistants and the nurse practitioners are not necessarily going into primary care. Less than half of the physician assistants are going into primary care, and we don't know exactly, but we think about a little bit more than half of nurse practitioners. Some of you have probably been doing some work on this. It's hard to define. I think this is what we had at HRSA. I don't know if you've found anything different than that.
The National Sample Survey of NPs just came out with a number too, and I'm not sure what that number is, but it's going to be sort of the definitive number, I think, because they did a survey of work settings. I'm thinking it's around 60, so not very different.
It's hard to sort of sort it out.
Yeah.
Yeah.
Do you have a breakdown for PAs and nurse practitioners?
Do I have the breakdown?
Rural urban breakdown. So I was under the impression that they did proportionately in rural areas, so maybe that kind of acts on the position.
Yeah, it depends on what you look at. If you look at, there are a few more nurse practitioners in terms of the total number of nurse practitioners practicing in the rural and frontier areas. But I don't have that. I didn't bring that with me. But it is a little higher than in some of the urban areas.
I think that's true for MPs. I'm not sure about PAs.
I think even for
PAs, I'm not sure.
Too. And then your work and others have shown that they're more likely to take Medicaid as well, NPs than physicians.
But the engine that got the NP and PA off the ground back in the 70s was all about rural and underserved. Mm-hmm. And many practice laws were modified in favor of increased scope of practice based on this was the answer to underserved area, which always was political, I think, because why would they end up in a different pattern than doctors had over the years, particularly if you weren't particularly recruiting people from rural areas or had schools based in rural areas. I think the underlying dynamic here is that any clinician in a country that's got opportunities will tend to gravitate towards what they want, and unfortunately that tends to be urban, tends to be well paid or better paid or less non-paying patients. So the dynamic is there as an economic dynamic or a labor fact, I think. And what has happened is that the PA and NP workforce has become distributed very similarly to the physician workforce,
Right.
They're very much active in specialties, which I think is important. Most people say, "Oh, that's a loss. That wasn't what they're supposed to do." But if you want to attenuate the growth of specialists, medical specialists, having PAs and NPs working among them is a way to do that. Particularly if you want to put more investment in generalist activities. If you have the specialists unable to say, "Oh, we don't have enough of us," when they actually have an integrated workforce, which they do. So it's a little off the rural point, but I think the underlying issue is the dynamic of a new specialty or a new profession, as these two are. And they're not intrinsically, a nurse practitioner isn't intrinsically any more rural than a physician graduate is.
Except to the extent that you have RNs who are already living in rural communities who become NPs and they stay there. And I think that's one of the reasons why you tend to have more NPs in rural areas. They do their graduate work later and then they stay where they were living.
Right.
Well, I think they might like having a little more autonomy, which often occurs in rural areas.
Because the state laws have been
But even to the extent that they may be working under the supervision of the physician only shows up in the clinic 1 day a week. So for the other 4 days a week, they're in charge.
Well, I think it depends on your perspective. I've certainly worked with a number of nurse practitioners who really prefer to have a closer working relationship with physicians, but because there is a relative shortage of physicians in rural areas, that nurse practitioner may be the only clinician. Mm-hmm. And many nurse practitioners really prefer to work more closely with physicians, but I think it really varies on the patient population and the practice style. Yeah. Just kind of moving ahead a little bit into GME, what I referred to before in terms of the training of the workforce and GME accountability. You all are going to recognize this paper that was published last year, 2012, where we started to take a look at, with Candace Chen and obviously Dr. Mullen and the Robert Graham Center, where you looked at 759 institutions and found that really so many of them were not producing primary care physicians. In fact, 158 institutions were not producing any primary care physicians, if I recall correctly.
These are GME programs.
Yeah, GME programs. Yeah. Well, these are the sponsoring institutions that you looked at. Yeah. And a number of them, a high number of them, were not producing any physicians to go into rural areas, and a very small proportion, 24%, going into primary care. So I think this was one of the first times that we've actually looked at teaching institutions to look at the real accountability for what we're getting for our investment in GME. Would you say that that's accurate?
Yeah, absolutely. GME has been way understudied. Lots of studies in medical school and their graduates and their location and their educational style, et cetera. But the truth in medicine, you've got three sources of physicians. U.S. medical schools, that most people think of that being allopathic, U.S. osteopathic medical schools, and until recently those communities were always treated as very different. People had numbers on one and not the other. And over the last 10 years, that's melding happily. And then you have international questions. So the answer, how do you get a doctor for America, is at three different educational routes. And very few people looked at that, and we looked at it in a number of ways, beginning to focus on GME and social accountability. What are the individuals doing? What are the institutions that produce them doing? And this paper was the first of now several more that are in the pipeline about GME outcomes.
Mm-hmm. Yeah.
A difficult area, there's so many more GME programs. There are 140, probably 160 medical schools, allopathic and osteopathic, but there are 7,000 teaching hospitals that have a program or more than one program. So it's a much more complicated task.
It's very complex, and it's very hard to track where the teaching is taking place because many of the programs have residents rotating in multiple different hospitals and settings and clinics, et cetera, and it's very hard to keep track of it all. It's based on the graduate medical education report that came out of the IOM in July, which I'm sure everyone is familiar with, which is going to require really congressional action to act on most of the recommendations in that report. There's a couple things I think that we could think about doing as sort of policy levers, I guess, to until some certain more sort of basic changes are made in terms of the way GME is paid for. And one of them is enhancing the Teaching Health Center GME program. And I'm relatively familiar with that program since I helped oversee it when I was at HRSA. It's a new program, as many of you know, and it pays for residency education in community-based settings. The other thing is I think we can create a little bit more opportunity, and I'll show you a couple of things in a minute, with the VA models, the Veterans Administration. And then, as some of you already have mentioned, I think Polly mentioned, there's some opportunities in the states to work either through the SIM grants, perhaps, demonstration projects, and also some of the waivers, 1115 waivers that are available to enhance graduate medical education training, particularly in areas of need for particular populations, whether they're rural or inner city urban, or around particular populations who are immigrants and so forth. Just a little word on the Teaching Health Centers. Most of you know that it was an ACA program funded for 5 years. And the biggest difference between the Teaching Health Centers and all other primary care training programs is the money goes to the sponsoring institution of the residency training program. And that sponsoring institution has to be a community-based ambulatory type setting, such as a community health center. So
the important one is, for most people in this room who won't know, the biggest contributor to GME is the federal government, $10 billion a year, and that's broken up by generated by two very complicated formulas for each institution. But it goes to the institution, not to the sponsoring program, and it's largely a hospital subsidy, most of us think, as opposed to a real educational enhancement. But the Teaching Health Center idea was to give the money to the people who are doing the educating and to do it in a different setting, the community. They obviously have to get hospital training, so each community contracts with local hospitals for the rotations for the residents. So it doesn't break up the basic notion of training, but it puts the leadership for it and the dollars for it in the community, as opposed to in a very stylized institution, a very intensive institution, the Academic Health Center.
Right, and there's really hasn't been no real accountability, as I mentioned earlier, by these teaching hospitals to show on paper where the money is actually invested. And so that one thing, and actually Dr. Molina is studying this, we're going to be able to find out through this, some of the work that you're doing and others are doing in the room, where the money is going that's supporting these teaching health centers, which is a great opportunity because we don't really know the actual cost. We know how much we pay for graduate medical education, but we don't really know how much it costs. So that's an important aspect, is really being able to have some definitive accountability for the funding and have a better idea of how much it costs. In fact, many people are starting to believe that it's going to cost more to train residents in ambulatory settings and outpatient settings than it costs to train them in inpatient settings, which is a little bit surprising because people think because the patients are sicker in hospitals, et cetera, it would cost more, but that may not necessarily be the case. So currently there's 60 programs. They're in 24 states. We're supporting about over 550 FTEs. That's a full-time equivalent resident. The projection is that over the next year, when we increase the number that are currently, like if you have a 3-year program, you have started with the first years, and you increase to add your second year, because most programs are 3 or even 4 years, that will increase by 202 residents next year, and maybe another couple of hundred the year after that. So we may actually ramp up to about 1,000, up to 1,000 residents if the program is continued to be funded, which is, of course, everybody's got that question in their mind. Family medicine, as I mentioned, has a strong uptake, as well as osteopathic programs, because the osteopathic programs in many ways had to jump through a few fewer hoops to get their accreditation and qualify for the program. I want to just speak quickly about some of the things that have been going on in the VA. And last summer there was a lot of attention on the VA because some of the veterans couldn't get access to care, and there was quite a bit of upset. But over the last number of years, the VA really has developed a lot of sort of innovative practice models, including the Patient-Aligned Care Team, or PACT. They have a much more sophisticated, all-inclusive electronic medical record that they've developed over the last decade. They have a 5-year program which started the same year as the Teaching Health Center program, called Centers of Excellence in Primary Care Education. It's an interdisciplinary training program. They're training medical residents, nurse practitioners, pharmacists, and social workers and others in a care team idea, and they're having some very good results from that. And they've also the VA has worked hard to get more mental health access and integrated mental health care over the years. And then the final thing that the VA has done in the last about 8 years, I think, is developing these outpatient community-based outpatient clinics, which are known as CBOCs. I think at this point they have over 900 new small clinics throughout the nation. And with the VACA, which was the Veterans Access Choice Accountability Act, I think that's right, the Veterans Access Choice and Accountability Act, which was passed just, I think, in August, 1,500 new GME positions are authorized over the 5 years. So a new application just came out and is currently closed, and the VA is evaluating that. So I think that they'll be able to get some positions up and running by July. The thing is that the important aspect of it is that they're really looking at primary care, mental health as well, but looking at primary care providers, so internal medicine and family medicine mostly, pediatrics less so, probably, just because of the age of veterans. So what was I going to, make another point there, I forgot. So this is a map I put together for a presentation I did for the VA. And I just want to have you just take a look at this, because this is a tool, the type of tool that you can use, and you've probably used some of these types of tools, to take a look at where we can overlap efforts with the Veterans Administration. So the dark counties are counties where we expect a larger veterans population in 2020. The stars this is for family medicine. The stars are where residency programs currently exist. And the dots, if you can see the green dots, are where there are VA facilities. So one of the aspects about the VACA law is that the provision of care has to be, in Veterans Administration setting. So these CBOCs and other outpatient settings are perfect environments for training to care for the veterans. For family medicine, I don't know what it is for internal medicine, but for family medicine, you can go ahead and see patients in a continuity setting in those sites and receive credit for your training in an actual veteran site. So doing a little mapping exercise like this is what I call a mini whammy. It's Washington, Oregon, Idaho, and Montana. We can start to see opportunities for expanding training. So this is an area where we can start to expand training, to do appropriate training for a population that has a high need for both primary care and mental health, that you can just go right out of the box. Just a couple more things about the importance of comprehensive care and primary care. If you look at the ratio of primary care to physician population and look at costs, you can start to see that the more primary care physicians you have available, and I don't have this for nurse practitioners, but you can see that there is some savings in costs and efficiencies in care, even after controlling for these determinants of health. Comprehensive care, the x-axis is a measure of scope of care, so comprehensiveness of care again, and then the y-axis is the amount of money spent. So it's cheaper to have generalists with multiple areas that they care for, whether it's children, maternity care, office procedures, et cetera.
Raise another question. So this is sort of this notion of the relationship between density of primary care physicians and cost. I know I've done some analyses that basically look at sort of density of primary care relative to uninsurance levels, and so you find areas that have high levels of uninsurance tend to have low concentrations or low density of primary care physicians, and I suspect physicians in general. I mean, and my assumption has been that essentially speaking, people aren't going to practice that much in areas where they don't have paying patients. It's why do you not build your store in a urban area or a nice suburb as opposed to the inner city or rural areas? You go where the money is, and if that's the case, it could be the reason that you're seeing the association with cost is really because the areas with low densities of physicians have more uninsured patients.
Well, I think this was Medicare data, so they were all by definition insured. So that was sort of equalized that.
Okay.
Yeah, but that's a huge issue. I mean, it's a huge issue in terms of the distribution of physicians in the United States, right? If people, and it's part of the purpose, obviously, of the Affordable Care Act is to get people the insurance that they need so they can access care. And it's an issue with our social responsibility, I believe, as physicians, to figure out ways to care for patients who don't have money to pay or access to insurance, right? It's a very good point. Thank you for bringing that. So we did, Bob Phillips did this study, published, I think last year, just looking at physicians who train in underserved settings, do return to practice in underserved settings. Where you train, the type of setting you train in does make a difference. This is some data that I think is going to be published next month. Just look at the lower set of the adjusted numbers. If you look at a hospital referral region that has low, average, or high expenditures, and then look at the patient beneficiary where the costs where a physician locates. So let me just walk you through an example. So if I'm a physician and I train in a low HRR and I remain practicing in a low HRR, my average spending per beneficiary is low. If I train in a high HRR and remain in a high HRR, my spending is highest. There is some waning effect of this after about a decade, but what we're seeing is that people who train in a high HRR and perhaps go to a low HRR, their spending remains higher, but not quite as high. So where we're training really does have an imprinting effect and has an effect on outcomes. We are seeing shrinking scope, particularly for family medicine, maternity care. There's some evidence that the ACA isn't necessarily supporting some of the comprehensiveness of care in prior years based on rewards for primary care. There's not as much of a reward for comprehensiveness as we had hoped.
Shrinking its scope, you don't mean from a regulatory perspective, but from the relative payment perspective, the incentives to have a broader scope?
Right.
Financial incentives.
Financial incentives, right. And practice incentives to some extent as well. Yeah. This is just a mapping tool that we've developed at the Graham Center that basically looks at residency training programs and where residents go after they finished a training program. So I just picked out two from Ohio. So the green star is where the program is. So this is Metro Health Family Medicine Residency Program, and the red areas show where the residents ended up, and they're geographic areas, so it doesn't have anything. The size doesn't have anything to do with the number of residents. It's just a way of showing where they are. So I don't want you to think that Los Angeles is a big county. So this is Metro Health, and then this is Mount Carmel, also in Ohio. And you see where their residents are. So took a look at, what's the difference between this program and this program? Clearly, Ohio is interested in keeping their physicians there. And I think it kind of comes back to some extent about the accountability issue. Who are we training? It turns out that Mount Carmel's family medicine residency training program recruited their residents from people who did undergraduate work in Ohio, or they went to medical school in Ohio. 20 of their current 21 residents, when I looked at this in the fall, had some undergraduate degree locally. Whereas Metro Health, most of their medical graduates that they were training were from outside of Ohio. Many of them were international graduates. I'm not saying anything about international graduates except to say that they may not have had, similar to what we were saying before, they're not sort of socially bound to Ohio. So just a reminder of who we recruit into our program, how we train them, has an impact on where they end up practicing. So just in terms of where people practice and where they get their training, it's just really very important. You know how we're training people, and starting to think about just practice solutions and investment in infrastructure makes a difference. And I'm just going to go through a little bit of an exercise here. This is just sort of what I've talked about already, which I won't review. A lot of people say they go into primary care and they're like, "What was I thinking?" I'm burned out. The technology is not helpful. Student bubble. Gee, I should have gone into something else. Maybe I'll just if I can't get a great career, I can at least get better paid. The feeling of the hamster wheel. But there have been some interesting reports coming out. I don't know if you all know Christine Sinsky and her husband Tom, who've looked at practices to see where can we start to make a difference in practice. And so if you look at the complexity of the work, the vertical axis, and then go across the bottom for level of training, in the middle, there's sort of a matching of the level of training as well for the complexity of care. On the upper left, the work is too complex for the patient, for the provider, and it could be unsafe. On the bottom, the worker may be overtrained for the level of complexity. So and it's inefficient. So right in the middle is where you really want people to be. You want the less trained individual to be doing less complex care, and the more highly trained individual to be doing the more complex care. I'm not sure I said that correctly. But in any case, if we look at the lower right, we're seeing that a lot of doctors who have 7-8 years of post-baccalaureate training are doing inbox management, medicine reconciliation, script renewals, et cetera. It's inefficient. At the same time, things that are important that a doctor is well trained to do, such as end-of-life care, biopsychosocial care, chronic illness management, is a good value. That's where we want our doctors to be performing. If you start to take some of these things from the high complex, put them in a lower complex workforce, you start to see that some of that inbox can be cleared, where some of the management things can be done by people with 2 to 4 years post-high school care. It allows a greater MD flexibility and matches the complexity with the level of training. Well, there's new stuff coming out now with the PCMH. There's new requirements for the patient-centered medical home for things such as registries, patients and populations management, case management, coordination of care, hospital referral and coordination. And there's also now an expectation that physicians start to lead teams. So these care coordination activities really should be up here at the top where the physicians are working. They shouldn't be doing some of the less complex work. At the same time, people who have 2 to 4 years of post-high school education are much more interested in doing things that are more involved with patients, such as medicine reconciliation and referrals and coordination. So what we can do is start to enhance the value of primary care and the practice of primary care by assigning people the correct appropriate roles for their level of education and training. And I think that that's what the Sinskys are talking about when they published this paper called The Joy of Practice. Again, investment in primary care is 5% of the national amount. we're seeing if we invest a little bit more in primary care, we're getting high returns on our investment. State of Rhode Island had a good model, and Illinois did a nice model a couple of years ago showing a 33% decreased spend in some of their Medicaid populations by investing more in care coordination. So I want to finish up. I think we're starting to see that the science is there, the effectiveness of primary care is there, comprehensiveness of care is there. We need to figure out how to move the dial and put policies in place that support these efforts, promote and support generalism, and invest in the primary care workforce. John Lennon said a dream is a dream you dream alone is only a dream. A dream you dream together is a reality. Just a kind of a way of thinking about if we can start to come together and see how we can improve through policy, through working together, through recognition of the importance of generalism, we can start to make a difference in our field and our patients and our populations. So I'll stop there. I know I talked way too long. So thank you.